So since radiation is a field which, very few people know about the finer details of it, and still, you should be knowing it, because the patient comes back to you asking that, the doctor is advocating these types of treatment, and particularly in radiation, there are different types of techniques as well. So they would want some reinforcement from your end also, so that they can understand that the treatment is heading in a right direction. So we know it's a tremendous health burden. Looking at even my own clinical practice, I see that almost 40% of my patients, I'm a generalist, I treat patients head to toe, are from the gynecological malignancies. And endometrial cancer, though it has been a disease where we talk that US rates have been higher, we are seeing much numbers in Delhi NCR. Same is the scenario for prostate as well. I think the lifestyle changes, the food habits, all these are changing our disease pattern. So of late, we are seeing quite a lot of endometrial cancers in our practice. Cervical cancer, because of our screening measures, the vaccination drive, and a little bit of awareness rising, a little dip has come in, but endometrial are increasing. And these are, the incidence and the mortality rates which are prevalent in and around our country. And there has been a significant advancement. I believe Dr. Rashmi is going to talk a little bit about the surgical advancements, but a lot of things have happened in the last 10 years in the landscape of oncology, and which has hugely, hugely affected our practice of gynecological cancers management as well. Our diagnostics have become more efficient in picking up diseases at an earlier point of time. At the same time, the sensitivity and specificity of conjoining multiple modality imaging has yielded an increase in picking up diseases where decision making is element in terms of radiation versus surgery, or at times, fertility sparing versus non-fertility sparing. So our tools and armamentarium has increased. At the same time, we all talk about the personalized medicine. So I think endometrial cancer is one cancer which actually has got a major boost by personalized medicine. Because if you all remember, the only thing we used to do for any malignancy was FIGO staging. FIGO staging ho gaya, uske baad iska ye hoga, iska ye hoga, iska ye hoga. So we had 4 groups, stage 1, 2, 3, 4, and the treatment takes off. But in my few slides, you will realize that now endometrial cancer is in itself a big spectrum of disease. It is not being just divided into 4 stages. Beyond stages, there are multiple other parameters which are to be evaluated initially and even after surgery in order to define the correct line of management. So in diagnosis, we are having now functional imaging. So we all get MRIs done. And for oncology perspective, we always mention diffusion weighted images. So if you are at your clinic investigating a patient with some intent or your clinical doubt of a malignancy, prefer to get a diffusion weighted images done. In diffusion weighted images, they give you some ADC values. So ADC values of inflammatory versus malignant diseases are different. So your radiologist will be more categoric in telling you whether you're dealing with a mitotic etiology or it can be something inflammatory. So that is what should be done. Wherever you are suspecting malignancies, do mention diffusion weighted images. There are 2 important things. Firstly, it is helping you to differentiate from benign diseases. Apart from that, when we've treated the patient and on follow-up, we are comparing, a baseline will help us to even see how these values are changing. So if there was a diffusion restriction in a particular part of the tumor, if that diffusion restriction has gone, that means tumor has responded. Because mostly after radiation, radiologists also find it difficult because post-radiation changes are confusing. There will be areas of patchy enhancements, there will be heterogeneities, which they may not be able to differentiate unless you have a functional tool. Few people prefer to do PET-CTs also, but I would say PET-CT has a better yield for metastasis. It is better when we have stage 3C1 cancer, you want to see para-aortics and others. When you come to the soft tissue anatomy, the standard of care or the gold standard remains to be an MRI. Because firstly, there may be a case where surgery versus radiation, particularly cervical cancers, it holds true. You may require that information. And majorly all our radiation planning guidelines, nowadays whatever we are doing it is all computerized. We are delineating even a millimeter of tissue. Those guidelines are MRI based. Even our brachytherapy has evolved and become MRI based. So that is why prefer to do an imaging which is informative to you, as well as we don't have to repeat those tests over and over again, because patient इससे भी परेशान होता है कि मैम पिछले 2 हफ्ते से तो सिर्फ टेस्ट ही करा रहे हैं. So if the first test is right, maybe you can cut down the trail of the subsequent 2-3 tests at your own end as well. PET CTs we are doing for bad histologies where you are seeing heavy node burdens, or maybe at a later date where you are wanting to do a response evaluation. बहुत बार तो patient pressure में PET होता है, to be frank, because patients ask for it and the dictum is that later on, by chance, God forbid, something happens, patient will say, I wanted a PET, you did not. But ideally, PET is not mandatory for all malignancies. It is discretionary to you. You, based on adverse features, disease burden, can decide whether PET is required or not. Based on this new evidence of imaging, पहले FIGO हमें बहुत ज़्यादा discretion नहीं देता था for doing lot of tests. If you remember, for cervical cancer also sigmoidoscopy, rectosigmoidoscopy, IVP. So all that has changed after 2018. They have allowed lot of imaging, because now based on imaging you will have all these parameters, because now in 2023 the endometrial FIGO staging has changed. And if you look closely, there is a lot talked about the lymph node metastasis. So you want to pick up lymph node metastasis, and stage 3, just like cervical cancer, has been further subcategorized into stage 3C1 and 3C2 based on the presence of pelvic or para-aortic nodes. Another thing which you may not find in the initial imaging and may be evident after the final histology is there is a very important role of LVSI. So if surgeries are being done, do make it sure that the pathologist is mentioning LVSI, particularly in terms of the amount of LVSI. So there is a focal LVSI and there is a substantial LVSI. Focal LVSI is a favorable. Even if LVSI is there, we will not additionally add external radiation. The moment the word substantial LVSI comes in, even if it is a tumor which has invaded less than 20% myometrium, external radiation will be required. So LVSI is something which you should see in the reporting. If it is there, especially substantial, will merit external radiation as well. Something which has changed for the ovary. So this is very confusing. Even I also go back and reread it again and again. So if it is a low-grade tumor with ovary involvement, then it still remains 1A. But if it is a high-grade tumor with extrauterine extension with ovarian involvement, then it becomes stage 3. So ovary alone in itself does not upstage it to stage 3 unless there is extrauterine disease or there are substantial LVSI or aggressive histology and extrauterine spread. So this has changed tremendously in 2023, and practices also have evolved after this new staging has come into place. Because many a time it may be incidental. आप लोगों ने hysterectomy किया है for something and it turns out to be malignancy. Then those reports you should speak to your pathologist so that they can put a full objective detailing of all these parameters so as further line of treatment can be defined. The other thing which I mentioned, that now endometrium is not a single disease. It has expanded its tenets to lot of subcategories. That has because of the molecular based features which are coming in. So if a patient has undergone an endometrial biopsy upfront, also now patients are, it is a oncology community consensus that you should subject the patient to molecular testing right away on the initial endometrial biopsies. However, if patient has not done that molecular staging there, when the final histopath is done, our adjuvant treatment decision making is based on categorization of this molecular staging. So for molecular staging, you need additional tests. So these are the POL-E, P53, MMR, MSI, which is mandatory, because otherwise histotype alone has its own ambiguities. आप दो pathologists को दोगे grade में कभी कभार there may be a difference. Somebody may say a grade 2, somebody may say grade 3, and grade 2 and grade 3 will change the treatment decision emphatically. So to relieve these ambiguities of histotype differences between different centers, molecular is something which has come in to precisely categorize these patients. So it is you have to incorporate these, and based on these, so पहले हम ऐसे treat करते थे. We used to ascribe some risk stratification. So once a patient of endometrial carcinoma used to come to us, so we used to see what is the stage, whether LVSI is present or not, what is the grade. So based on these parameters, this was the ISJO risk stratification systems. So lymphovascular space invasion is on the histotype when you are seeing that the lymphatic spaces around the cellular tissues, if they are invaded. PNI is also something which is there, but that is not risk factor for gynecological malignancy. Sometimes tumors are going along the nerves. It is a majorly risk factor we are considering for head and neck malignancies. But LVSI is something which is elemental to decide. So apart from stage, you see the moment molecular classification came in, now we are starting to add POL-E, MMR, NSMP and P53 into this risk stratification. So if somebody has done these tests, then risk stratification changes. So it is important that you do guide your patients that these tests should be done, because these are costlier tests, especially POL-E. It is a test which it is not available in most centers. They have to go to molecular labs, and it is one of the tests which is done by, it cannot be done on IHC. It is not validated on IHC. Although for P53, even immunohistochemistry based sensitivity is good, and we are accepting those reports. But for POL, additional cost is added onto. But as of now, I would say, I think as of now with POL, we still have certain ambiguities. For low risk, it is important for decision making. For high risk, abhi studies nahi aayi hain. We are still awaiting results from a lot of studies. There's a study called PORTEC 4A which is going on, which will guide us whether based on POL you can omit treatment or not, because POL is a good type. Jisko POL positive hai, that means it's a good tumor. But just POL positivity should not indicate ki no treatment at all, because still POL has a lot of subvariants, pathogenic subvariants, so that is still under academic research, so we can't move with that. But if you have done these molecular testings, another big change which came in this FIGO 2023 staging was, agar stage 1 bhi hai, but it has a P53 mutation, the stage is upstage to stage 2C. So irrespective of the amount of myometrial invasion, whether it was just a polyp which was malignant, the stage changes to stage 2C. From treatment, though guidelines say that for a polyp with P53, do not go very aggressive, because once P53 is positive and it is stage 2C, the treatment becomes concurrent chemoradiation. You have to add chemo also along with radiation. And brachytherapy has its own subsets of indications or not. But P53 to sabka karana hai, because that is the bad element. And if it is POL positive, then the stage, irrespective of cervical extension, irrespective of LVSI or histotype, it becomes stage 1A polymute. So ये दो सब stages add हो गई हैं 2023 onwards, and decision making of treatment is again based on these. So what happens, as I mentioned, if somebody is POL mutated, then adjuvant treatment may not be required in some early stage diseases, and there will be an escalation of treatment of patients who are P53 mutated. It can be done on immunohistochemistry. It is very sensitive and specific on immunohistochemistry. Few people say that if it is positive, क्रॉस चेक कर सकते हैं आप फिश पे, इफ़ यू फील दैट यू आर नॉट कन्विंस्ड विद इट. बट एज ऑफ नाउ, इफ पेशेंट इज एक्सप्रेस्ड, तो रिपोर्ट क्या आती है? पोल, जब P53 की म्यूटेशन की रिपोर्ट आती है, तो दे विल राइट वाइल्ड टाइप और दे विल राइट म्यूटेटेड. सो वाइल्ड टाइप मीन्स नेगेटिव. So if POL mutation, if P53 के आगे लिखा है wild type, that means it is not an expressed. If it is expressed, it will not be wild type. So based on these mutations, these are the new subcategories which have come into picture. So they not only help you in deciding treatment, they are also indicating the likelihood of outcome as well. As I mentioned, POL mutated have excellent outcome, 5-year survival, 90 to 200%. MMRD has 80 to 90% survival rates. P53, poor outcomes, and they are the ones where you had to add a lot of additional treatments, including chemotherapy, and if it is metastatic, then PARP inhibitors also. NSMP is like, there are a mix of few mutations. They are not been classified in a particular subcategory. So there overall it is heterogeneous, and the survivals are ranging between 75 to 80%. And in the subgroup, sometimes some hormone manipulation may be of additional benefit. So these are the personalized medicine indicators. So these molecular expressions can help us guiding in if somebody can be eligible for certain personalized medicine. Independently, radiation has also evolved in the last 10 years. As I mentioned, diagnostics has evolved, our staging patterns have changed. Radiation, when I started training as a student, we used to do the 2D technique. We used to just make a square over the pelvis, one anterior, one posterior, and whatever is coming in that square, everything used to get the same radiation. But now our machines have these leaves, so they move and they can take different shapes so that we can conform our treatment. So what happens? So this is what we were doing when we were doing 2D. So for example, if this is the tumor, and this is a normal structure. So when we were giving radiation in the 2D era, this red area is 100% dose. Everything was getting same dose. It was not discriminating. So when we started increasing number of fields, and as in now we are doing IMRT, this is how our radiation beams are. So now your 100% dose goes only to the tumor bearing area. However, there is low dose which is there outside. But that low dose is so low that it does not cause clinically significant side effects. So that is the difference. As you can see now, rectum is getting green. So blue is representing 50% dose, green is somewhere representing around 65% dose. So the reduction in dose has happened. And on that, we are now having image guidance also. So the linear accelerators on which now radiation is done, they have inbuilt CT scanners. And nowadays, there's one machine with an MRI also which has come in our city. So before the patient starts the treatment, a small low energy scan is taken. That scan is matched with the first scan. So when you see that, they should be carbon copies of each other. You can see in X, Y, Z coordinate by bone matching if your patient has moved. Because movement hoti kahan hai? Because patient loses weight, the mass gets loose, so they start getting shifting here and there. Secondly, for pelvis, it is very important that soft tissues are also at the same location. So majorly, it is the bladder filling, the rectal filling, which can change. And with the bladder filling, the uterus axis changes. So that can be monitored in these IGRT techniques so as we can understand where what organ is situated. So this is how now we do treatments. We identify exactly where the tumor is, where the node is. We delineate these areas. And then our medical physicists who are scientists, they apply certain algorithms and these plans are generated. These plans are evaluated by the oncologist. There are specially norms and thresholds been given that for this organ you will not exceed this. Once all those have been achieved, then we schedule the patient onto the radiation machine. Machines are run by technologists. The technologists run the machine, but those image guidances are supervised by oncologists because sometimes technologists cannot know about the organs. They are aware of bony landmarks, but finally we have to match. So ab radiation dose aise dikhta hai. Rather than that square which I showed you in the 2D era. So this is the vagina, the uterus, the presacral nodes. This entire yellow area is the one which I want to treat. Small bowel is protected. More importantly, bone marrow is protected because 50% of the marrow is in the pelvis. Patient is also receiving chemotherapy. So that additionally is leading to low counts. So when you are able to protect the bone marrow, patient's overall treatment experience is better because lesser infections. And of course, few side effects we can't divorce. There will be certain side effects. Fatigue is a systemic effect of radiation. It still remains to be there. Mild nausea, vomiting happens to most of the patients. And again, nausea, vomiting varies patient to patient. Few patients say, I did not take a single tablet of yours for nausea. Few patients require 3 to 4 different concoctions to take care of the nausea, vomiting. But from chemo side also, very nice drugs have come in wherein the emesis is reduced because we give cisplatin with radiation and cisplatin has a very high emetogenic potential. So these drugs are of value. And पहले जब हम radiation करते थे ना, avascular necrosis, hip, these complications were also very common. So now we are able to reduce doses to these organs as well. So that has also improved the quality of life of patients. See, longevity, a lot of things are happening, but when patients live longer, they come back to you with sequelae. So now major focus of treatment is towards sequelae. AI has been a major player in radiation oncology for the last 10 years. Some amount of AI has been applied in our algorithms. As I mentioned, there are scientists who are calculating these. So patient ka jaise tumor shrink hota hai, the moment it shrinks, the machine also knows there is some change. So based on those shrinkages, the machine is adapting. So all these adaptive treatments have, because of the AI tools, which have improved our treatment delivery. And this, as I have already talked about, quality of life is important. You know, we cannot send a patient in community who has a stigma because cancer se stigma se hi log darte hain. We want a patient to go back happy and not a patient anymore feeling. They should not be feeling that they are different in the community. They should be well adjusted in the community. So for that, we try to have as much preservation of organs. So post-op case में आप क्या preserve करना चाहते हो? आप vaginal health के बारे में worried हो. If there is synecdoche, vaginal dryness, that is also a quality of life issues. Patient may not express it overtly, but many a times patients, when you examine, you see there is fibrosis, they're not sexually active because of the sequelae of these treatments. So there are a lot of constraints being given for vaginal mucosa also, that when you are treating these patients, to ensure that the vaginal health is also maintained, you have to ensure a good radiation. This is a small example, just showcasing how radiation has changed in a way that it's not replacing surgery, so don't take that message from this case, that it is safe in very fragile, very elderly patients also. This is one of our patients. She was 83-year-old at presentation. She came to us with a diagnosis from the Armed Forces College, Medical College, with a grade 3 adenocarcinoma. And she had undergone a TAVR. So surgically, she had been refused as a medical, contraindication for a surgery. So when she came to us, firstly we told her that for CS cervix, we know radiation works wonders. We can have 80 to 90% cure rates with CTRT alone, but endometrium sometimes may not respond, but we can try. So we gave her external radiation, 50.4 gray in 28 sittings over a period of 5.5 weeks. No chemo was given. 83-year-old, she was very frail and was having already polypharmacy. At least 12 medicines were there in her prescription before she came to me. After that, we did brachytherapy. So brachytherapy for endometrium is different, because for cervix, you want to treat the cervix area, you want to treat the uterine cavity and upper third of vagina only. But for endometrium, we have to treat 2/3 of vagina. And certain histologies like clear cell carcinoma, we have to treat up to lower third of vagina. So the applicator for endometrium is different. So there is a tandem, which is a tube, and then these are the rings which we have put onto the tandem. Few very different applicators are also available, where you are pushing 3-4 different tubes into the uterine cavity, but their availability is not very much in most of the centers, because mostly 95% cases come to us as operated cases. So those can also be sometimes utilized. So this is her scan. She has been on follow-up with us almost 1.5 years, and there is no evidence of disease so far. And she walked with us in the ramp on our cancer survivorship day. Knees were hurting, but she came herself, absolutely taking care of her own medications, absolutely fit and fine. And fortunately, the outcome was good. There were a lot of apprehensions during brachy also, because this brachy was done under anesthesia. So she had tachycardia, had to be given lignocaine in her first setting. Ma'am, because we have to put a tandem inside. We were not sure that whether tandem could have been. Had it been post-op case for sorbo or CVSA, we don't need any anesthesia. That is our minor OT procedure. But we were anticipating, and anxiety at her and our end both was equal. Because if she had tachycardia in minor OT, my anesthesia people would have hung me. कि क्यों नहीं लिया था आपने under anesthesia? Why you took overzealous step and did it under minor OT? So with safety, I think it was a better controlled environment. Even that environment was enabling for me also to do the procedure comfortably.
तो जो टेंडम है वो GA में डाल देते हैं
और वो भी हाँ तो मैम क्या करते हैं, we put the applicator inside. So for any brachytherapy procedure, we put the applicator.
It is same for all the brachytherapy.
So after the applicator is put and patient is slightly alert, we do a CT scan. During the CT scan, we put some contrast in the rectum and some dye in the bladder. And then again, just like external radiation, we draw everything on those CT scans and then ascribe dose. Once the plan is ready, then we shift the patient to the brachy suite. वहाँ पे the machine has channels. We attach those channels to the applicator and radiation is delivered, and then we take off the applicator. These are simpler procedures. I think the most complicated or the most demanding from the patient and our perspectives are the interstitials. Vault recurrences or certain bad anatomies where you can't put a tandem and avoid, we have to put needles. So there we have templates, and we sometimes put as many as 18 to 20 needles. 20 centimeter needle may say almost 12 centimeters in the perineum. So there I keep these patients in the ICU, because patient has to be in a strict supine position and nursing head be flat rakhna hai, so the care is better there. And removal of that applicator also has the risk of bleeding. So that is a more demanding one. These procedures are relatively simpler otherwise. The patient has to be very cooperative, because some sedation definitely is required. So ma'am, it depends on your source strength. When we are doing brachytherapies, we do it with iridium. So when we get a fresh source, sometimes within 7 minutes the treatment is over. जैसे सोर्स पुराना होता जाता है, it is 2.5 months old, the source strength goes down. So to deliver same amount of radiation, the time increases. So that time, sometimes you have to spend 40-45 minutes also. So it's on the source strength. बिल्कुल बिल्कुल. For external radiation, ma'am, there are 4 rules of radiation. We call them 4 R's of radiotherapy, which are based on tumor repopulation, repair of normal organs, reoxygenation, and redistribution. Because cells keep changing. So if you give entire radiation at one go, there will be some cells which will be in G0 phase, which you will not be able to kill. So we want those cells to come back to that phase where we can kill them. We can kill cells in G2M phase of cell cycle. That is the most sensitive phase. So that is why we fractionate or divide it into multiple sessions. 2 days which we give are for the body cells which are normal to repair. So that is why most radiation fractionations you will see would be 5 days in a week, Monday to Friday. That is the schedule. Few radiations, like in metastatic setting, where you are giving a different dose, we are doing very high dose per fraction, we call it SBRT. There you may do it on a non-consecutive day. For example, you did one on Monday, then you call patient on Thursday, because then you are giving 8 gray, 10 gray, 12 gray in one day. Normally, we are giving 1.8 gray to 2 gray every day, which is the conventional fraction. The word we use is conventional fractionation. Otherwise, if it is hypofractionation, very high dose, then the frequency is reduced. Brachytherapy mein, we keep a week's gap. If we have done first session on one Monday, then the subsequent sessions of cervix are done weekly basis. However, interstitial is different, because you have put those needles inside. You can't take it out every week and put them every week back. There are centers, when I learned this at AIMS, they were doing weekly, because they said that we cannot keep the patient with the needle. We haven't built that practice yet. I don't know what is the current practice, but every week the needle was put, patient was treated, next week the needle was put back. So what I felt and what my practice at other centers where I previously practiced, we feel that hematomas ban jate hain wahan pe. So when you put it next time, you are causing more mutilation, the chances of perineal abscesses, infections, and later pain, 6 महीने बाद भी pain हो रही है. That was more common in patients who are going for repeated interstitial at fractionated weekly basis. So what now most of us do is, अगर आपने सुबह applicator डाला है, so doing the entire CT scan planning will take the day's time. First session is delivered by the end of the day, and then at least 6 hours gap has to be maintained. So another day morning, then evening. So mostly 5 sessions is what we are doing in interstitial. So patient remains in the ICU for 2.5 days. Once the applicator is out, there is no bleeding. The same day we shift the patient to the ward, and next day patient is discharged.
Before neck fractionation, so you do hematological monitoring?
Absolutely, ma'am. Absolutely. Because you have to catheterize.
There, then you can't take the next dose.
So before every brachy, previous day we have a CBC, and my practices, and I have published as well as I got a Stark Federation first prize for this also. I use mesoprost on the previous night also, so that your application is eased, because when we started it, many times it is so soft, false tracks ban jate hain, and everybody is not that luxurious to have intraoperative ultrasounds. Your ultrasound machines are in echo, they are there. You can't be just waiting ki machine aayegi to main procedure karunga. So I started, Dr. Satinder was the gynecologist with me. She said, why didn't you try? So it was a joint effort, and I published that also, that the number of false rates, and so it eases out. But many a times if there is fibrosis, there is endocervical growth, then there is a challenge. But CBC is mandatory, because apart from the procedure, you have to put a catheter. So risk of urosepsis also increases. And sometimes if patient has urinary symptoms, I also ensure that urine report is also normal. If there are pus cells, then I would defer the treatment by 4-5 days. But having said that, ideally radiation for CS cervix or endometrial cancers should complete within 7 to 9 weeks. Overall treatment time of 9 weeks ensures better outcomes in terms of local control as well as survival. As the gaps increase, chances of recurrence are more higher, because वो जो मैंने आपको आता है ना 4 hours of radiation, repopulation ज़्यादा हो जाती है. So my learning from this case was that yes, we can efficaciously deliver treatment for geriatric patients also, and we should focus on quality of life. I think mostly all of us are cohesively working towards quality of life. So just to summarize my presentation, we know we are having advances which are enabling early detection. We are having minimal invasive surgeries. Cervix में नहीं करते हैं. We do reinforce that cervix में minimal invasive नहीं करते हैं. But for in terms of robotics, but for endometrium we have robotic assisted surgeries as well. Radiation techniques have transformed. We have very different techniques. I didn't talk of proton because it is not there in Delhi. So we have even advanced different types of radiations and targeted therapies in form of PARP inhibitors, antibodies, checkpoint inhibitors, which have improved the overall survivals of the patients and definitely the quality of life of patients which we treated 2 decades back versus what we treat now has changed tremendously. So thank you so much. This is our survivorship clinic. Dr. Davar from our, Dharmshala Foundation, she started this. This is for our survivors. So we do a lot of survivorship meets, and many of our survivors have won pageants and showcased that cancer does not take away your life or your beauty. And they become ambassadors for others as well. This girl here, she was a mother of 2 when she came for treatment. She went to Gladrax Mrs. India also, and she's a telecom engineer. She's left her engineering, now she's become a professional anchor. So cancer कई बार जिंदगी बदल देता है इस तरह से कि आपको ज़्यादा strong भी कर देता है, and there are living examples to it.